Okay, well, it's 9:30 here in Tacoma, so I think we'll get started with our meeting today. And we'll just want to start it by doing attendance and roll call. We'll start by thanking our host today, Stephanie Cowan from Multicare. Stephanie, would you mind just giving us a little bit about you and Multicare?
Yeah, welcome everyone. Thank you. I am the Clinical Care Director for Virtual Health here at Multicare, and I've been in the position for just under a year now. So thank you all.
Yeah, great, thanks. So John Scott, University of Washington.
Jamie Neal, University of Washington.
Randy Becker, State Senator, 2nd Legislative District.
Stafford Strong, Senate Republican Caucus.
John?
John Bowes with Labor and Industries.
Evan Klein with the Senate Healthcare Committee.
Great. And I think we're going to do first collaborative members who are on the phone or by video. Can we start with Denny Lorden?
Good morning, Denny Lorden, Providence St. Joseph Health.
Great. And Joelle Fathi?
Hi, good morning, representing Washington State Nurses Association.
Great. And I think we had Brody DeChinko as well. Brody, Happy New Year.
Hi, Happy New Year. Good morning. Brody DeChinko with Cambia Health Solutions and Regis Blue Shield.
Great. Thanks, Brody. Maybe we can do, just to make sure we didn't miss anyone on our regular member of the collaborative. So Chris Cable. Chris, are you on the line? Senator Cleveland. Kathleen Damon from Swedish. Chad Gavilan. Francis Guff. Cheryl Huchala.
I'm here.
Oh, hi, Cheryl.
Hello.
Happy New Year.
Thank you. You too.
Yeah. Dr. Jimenez, Ricardo Jimenez. Dr. Jones. Dr. Kie, Ryan Kie. Was that you, Ryan? I don't know if I heard that. No? Okay. Dr. Scott. Oh, hi, Senator Representative Schmick. Glad you were able to join by Zoom.
Well, I haven't got there yet, but you're on the phone anyway.
Okay, we can hear you. Scott Kennedy. Sarah Orth. I know Sarah was going to call in today. She's a little bit under the weather. So,
Yeah.
okay.
Hello.
Hope you feel better, Sarah. Thanks for coming. Adam Romney. Cara Towell. Hopefully Cara will join a little bit later. Laura Wakashigi. And Representative Roccelli.
I'm here.
Oh, hi. Hi, Representative Roccelli.
Hi.
Happy New Year.
Happy New Year.
Great. And let's just do brief introductions in the room of people who are from the public. If you could just state your name and which organization you're representing. We'll start with.
Good morning, Dave Harbaugh on behalf of OSHA.
Ian?
Ian Goodhue, UW Medicine.
And Kim?
Kim Sparling, Multicare Virtual Health.
Great. And then maybe Deb LaMarche. You can say hi.
Hi, I'm Deb LaMarche from the Northwest Regional Telehealth Resource Center.
Thanks for joining, Deb. Well, we're going to be talking about training centers during our talk today. So I think it'd be good for everyone to know what some of the resources are available to NRTRC. I know you guys have presented before, but just to be a good reminder of what's available there in Salt Lake.
Thank you.
Yeah. And let's see here. Lisa Roche.
Good morning.
Good morning. And Tracy Drake.
Good morning. Tracy Drake from Department of Health.
Great. Thanks for joining, Tracy. Anyone else who wants to say hi? I see Michael Matella and someone with the last name, maybe Kunkel or Kunky. Sorry. Michael, do you want to say hi?
Happy New Year to all from Everett Clinic.
Which clinic, Michael?
Everett Clinic.
Okay, thank you. And there was one other person with the last name Kunke. We just want to unmute yourself and say who you are. Okay, well, hopefully your audio is working. Anyone else who wants to say hello, who's a member of the public?
Marissa?
Marissa Ingalls, Coordinated Care.
Hi, Marissa. Sorry, I missed you over there.
And this
Okay.
is Stephanie Shushan from Community Health Plan of Washington.
Okay, thank you, Stephanie.
And Nancy Lawton from A&Ps United of Washington State.
Hi, Nancy. Anyone else? Okay. Well,
Hi,
so
this
the first.
is Cindy Jacobs.
Hi, Cindy. Cindy Jacobs from
Hey.
UW. Okay. Anyone else want to say hi?
Oh, hi, this is Lori Wakashige from Legacy.
Hi, Lori.
Hi.
Happy New Year to you.
Happy New Year to you too.
Oh, we're hoping to get down to Vancouver this year.
Yeah, that'd be great. Just let us know what dates you're looking at.
Okay. Anyone else want to say hi? Okay, good. Well, I thought what we'll do is dive right into the agenda. And the first order of business is to go over the minutes from November 27th. And let me just share those with folks. All right. Let's move this over. I'll give you a couple minutes to review those. So we talked a lot about training, and we'll continue that conversation today. And Adam led us through a discussion on proxy credentialing. And are those slides available on the website, Jamie?
I can make them available, yes.
Yeah. So we'll make, Adam, if it's okay with you, can we share the slides that you presented from last time?
Yeah, no problem, of course.
Okay, great. Thank you, Adam. And then we talked about the report to the legislature, which Evan, I think, has now been made public to the legislature. Okay, great. And it should be on the website as well. The WSMA website. We'll talk about the bills that Senator Becker wants to introduce or has introduced. We'll get some follow-up today on the technical assistance centers, and then hopefully finalize the collaborative schedule. I do want to first point out that our next meeting is scheduled for Friday, February 8th. And probably be back in the Seattle area with Providence Swedish volunteering to host. So we'll have details firmed up of that. We do have March 22nd tentatively penciled in and May 6th. These are kind of when we had met in prior years. So Jamie is kind of trying to follow the same cadence for that.
Do you have a time for the February 8th?
We have it 2 to 4.
Oh,
Yeah.
Yeah.
Tried to go off of what they were previously. So. And just a quick note on the minutes, Joelle had emailed me over some changes to the minutes. So the minutes that are included here have her changes already incorporated.
Okay. Great.
If I might make a comment, these notes are amazing.
Thank you.
You did a really nice job. The
Thank
detail
you.
was amazing.
Good. Well, can we entertain a motion to approve these minutes?
Make a motion.
Okay, Senator Becker moved. Do we have a second?
I second.
Okay, any discussion, edits, comments on the minutes? Well, hearing none, can we get a vote? All in favor to approve? Say aye.
Aye.
Okay, any who do not want to approve them, please say no. Okay, great. Well, these will be uploaded in the next couple of days to the WSMA website along with Adam's presentation last month. So let me just take this down. So the next thing that we wanted to talk about is a follow-up on the telehealth training. And there's been quite a bit of activity on that front with Sarah and Adam really doing yeoman duty since we last talked. So I don't know if Sarah and Adam, do you want to walk us through the changes since last time? Or how do you want to proceed?
This is Sarah. Yeah, that would be great. I'm just going to present at a really high level. And then also, Joelle, you can jump in because I know that you did some work on this and got some feedback also.
Okay.
So next slide. Here we added in the sources where we got those definitions and hyperlinks. Next slide. Here we added in that the information came from the Center for Connected Health Policy and is current as of October 2018. This is one of those sections that we'll need to update annually as these numbers change frequently. And we also clarified the language in the very last bullet, just to let providers know that there is a difference between what services are covered in law and payment parity, so that they should check the legislation for each state that they want to do business in. Next slide. Here I added a source at the bottom again. Next slide. This, Adam pointed out, I had a different Medicaid definition in here. So this is the correct one and a link to the correct source online. Next slide.
Sorry, can you just elaborate a little bit more, Adam or Sarah? What did we change here? It was the Medicaid paragraph, right?
Yeah, I just had different links
okay.
to the wrong thing, and Adam found that. I updated it.
Yeah, I wouldn't say it was the wrong thing. We had some language from the Medicaid billing manuals, and I just thought that the WAC definition of telemedicine for Medicaid purposes in our state is probably a better all-encompassing definition to include for training purposes. So the bottom definition is now the one from the administrative code.
Okay, thank you.
Here we added in a disclaimer about the scope of telehealth practice may be defined by each licensing board. No changes here.
So just one of my to-do list was to follow up with the various societies like the OT group, PT, the licensed social workers, and they either didn't get back to me or they said they don't have any kind of official policy other than what's linked on the hyperlink there. So I think for the most part, a lot of the information, the specific information is for physicians and physician assistants. That's what the most information is going to be there.
Mm-hmm.
Okay. So then credentialing and privileging.
There were no changes here. No changes here. No changes here.
And this is current as of, this is the most recent physician fee schedule from November 2018. Mm-hmm. There were some minor changes in the physician fee schedule for CMS. So a good example would be telestroke. They relaxed the rural requirement. So every year, it seems like Medicare kind of chips away at it. And I think that's where having a hyperlink is going to be really helpful for folks to just kind of see what the latest policy is. It's a really big document. The physician fee schedule is like hundreds of pages. But it is indexed, so people can kind of go to the relevant section. So, but Sarah, do you want to say a little bit more here? It goes through some of the restrictions on Medicare.
Yep, and again, the fee sheet, the fact sheet is linked at the bottom too, so that's great. And then the link so you can figure out if you're in a shortage area.
Yeah, if people haven't used it, it's pretty cool. You just type in your zip code. And the thing about that is every time there's a new census, that those zip codes may change. So there's some areas that might be rural as of the 2010 census that are going to now be considered to be suburban or urban in 2020. So I think that sometimes people don't understand that. Like every new census, there's a changing definition. Okay, this goes still Medicare with who can do it.
Mm-hmm.
So it's interesting that Medicare does not say anything about OT or PT, but it does say nutritionists, dietitians. Okay. So this is modality for Medicare.
Can I ask a question?
Yeah.
What is this, the CPS and CSWs? I don't know the acronym on the last slide, 13.
So CSW is a clinical social worker. And guys, do you know what CP stands for?
Clinical psychologist.
Clinical psychologist. Okay. Yeah. Okay. Oh yeah, it was just. Yeah.
Well, it looked.
Maybe we should like right here put CSW right after clinical social worker because it's just a line above Senator Becker. Yeah.
Got it.
Yeah. So that was slide 13. Let's make that change. Okay, so now on slide 15, we start diving into Washington reimbursement and reference Senate Bill 5175. And I think this is, Sarah and Adam, correct me if I'm wrong, this is just straight from the bill.
That's correct. And the changes that you'll see in this training deck from last time are that we kind of consolidated it. We had some of this information over a couple different slides in different places, so we made it easier to follow.
Okay. And then it goes over what is a valid originating site and includes home.
Mm-hmm.
Okay. And it talks about Medicaid, including store and forward, with even what modifiers to use. So that's really helpful. Seeing, is there a link here to Medicaid policy that maybe we should make?
I think we could link to the WAC site, or there is a discussion in the Physician Services Billing Manual from the Healthcare Authority that actually provides some pretty good kind of narrative explanation regarding what's covered by the state Medicaid program. I think that may be the most user-friendly information.
Okay, so we'll try to put those links in there on slide 17. It goes through billing documentation. And I think the real important stuff is there at the bottom. You have to document the service was provided by telemedicine. You have to document the location of the patient or client. And if there was any other associated medical personnel with the patient. I think, Adam, you may have written this one because you used client. I would probably use patient.
Right.
So if you don't mind, maybe we'll change client to patient on that one. This goes through the telehealth standards and guidelines with a lot of the links to ATA resources. And then links to MQAC standards of care. And then I think there, Adam, was this where we started made a little bit of changes from last time? Where informed consent? Is there any changes there?
We did. Let's see. So I think in the sample language, Sarah, you made the change. Maybe you can talk about it better than I can. But we tried to make the example language include the recommendations from the medical commission to, this Romanet 1 and 2 in the top paragraph talk about what the medical commission would like to see in the consent language. So I think we updated the sample language to include those two recommended elements. Is that right, Sarah?
Yes, that's right. I added in, kind of in the middle, I am a blank credentials provider. This text originally came from last year's telehealth collaborative recommended language, so I updated it to include those credentials. We also clarified the question because it had said something like, do I need to obtain a special consent for a telemedicine visit? So we made it more clear. There's nothing legally that requires you in the state of Washington to have a special consent for telemedicine. However, it is recommended by MQAC, and that is the language there.
Okay.
And that link is to, on the bottom, to the MQAC guidelines, document specific.
Okay.
Here we made a few changes to the slide too. The way that it was previously worded kind of implied that it had to be live video, and we know there are other modalities for telehealth, so we made that a little bit softer. And then one question Adam and I wanted to discuss with this group related to this slide was about phone only. So we've seen in the industry historically, some people include telephone only as telehealth. Most definitions of telehealth do not include phone only, but we do see Medicare, the new Medicare guidelines of the fee schedule is going to be reimbursing for some phone follow-ups. It's not technically, quote, telehealth, but we didn't know if we should include anything about phone in this slide, so wanted to bring that for discussion.
Yeah, what thoughts on that? Does that confuse people?
Well, I guess it begs to ask a further question. If it's not clear, or is are the Medicare guidelines clear as to what qualifies for a telephone reimbursement? Because we're specifically not in the Medicaid group. They're specifically not paying for phone, so I don't know what I'm asking here other than what are the true definitions of telephone from Medicare?
Dr. Scott.
Joel, that's a great, go ahead.
Go ahead, Joel.
I was just going to say quickly, there are telephone specific codes, and I think probably the defining factor here is audio video versus telephonic only in regards to being able to qualify the call as a telehealth visit. Denny, what were you going to say?
I was just going to say, since that it's Medicare specific at this point, although Medicare seems to be leading the way in e-consults and those sorts of things, maybe we just limit it to the Medicare section and keep ours. I don't know if we're going to be too forward thinking here.
Yeah. I'm just wondering if we could go back and just say, when we get to the definition, it was like maybe the third or fourth slide, and I can go back.
Slide number 6.
Maybe we say that it could be an asterisk or something like that, and say that Medicare does reimburse for phone only, but for the purposes of this training, we're going to talk about this definition. Then I think that way it keeps it a little bit cleaner.
The only other thing you might be able to do is put in a section on e-consults, and that's so new that it's probably going to evolve quickly.
Yeah. Yep. Danny,
Right, and you wouldn't use a. I'm sorry. Go ahead.
No, go ahead, Joelle.
I was just going to say, I don't know that you could really utilize a GT modifier to designate a telehealth visit with a telephone call.
Yeah. Right. So that's why I would say for phone right now, I know I personally don't get involved in any kind of phone related billing at UW. That's not my bailiwick.
So this is Cheryl. We do see a lot of telephonic telehealth visits, so I would think we might want to address it.
How are they billed, Cheryl? As telephone calls? Are they designated as telehealth?
They would be designated as telehealth, yes.
Is that how it's done? I conducted volumes of telephonic follow-up visits with my remote patients, but I only charge them as telephone. Our billing office wouldn't allow a GT modifier attached to a straightforward telephone call. It wasn't considered telehealth.
Yeah, so I'd have to, I don't know, I don't recall for sure exactly what modifier they would put on, but there are definitely, there is reimbursement for telephone telehealth codes.
Well, and so we should investigate that further. Telephonic visits are reimbursed by some insurance companies, but they're not reimbursed well. And, then you get into, there's all kinds of telephonic visits going on all the time. So, it's really kind of, are we going to drive a standard of care? And if so, we need to educate people on how to bill for that, because that's a pretty fuzzy area.
Yeah.
Yeah, I agree. It's pretty fuzzy. I think it would help to define it, though.
Yeah, we're not billing phone calls as telehealth, just as telephone calls.
Right. Same with us.
So no modifier, no GT modifier for the telehealth.
Maybe can I ask Brody and Cheryl to investigate that and see what is being billed, and maybe folks who are also with the Medicaid MCOs, would you mind? And seeing, are these being billed as telehealth visits with like a GT modifier, or is it the phone only codes? So I'm pretty sure at the UW we're using the phone only codes. We don't consider telephone to be telehealth. So that sounds like Stephanie.
Yeah, this is Brody, and according to our reimbursement policy, the telephone only codes, those 99441s through the 443s, we do allow the GT modifier to be added to it, and it does pay to the telehealth benefit.
Okay, so the 9944, what was the code? 99411 or 99441?
99441 through 99443 for physicians, and then for the non-physician qualified healthcare professionals, it's 98966 to 98968. I'm happy to email this to Jamie if needed as well.
Okay. Sounds like maybe we add a slide on telephone only and say these are the codes. And I think a lot of us are saying this we don't consider telephone to be telehealth.
Well, I agree, but what's bothering me with this is if we utilize this definition, which I like, but knowing that technologies are going to change so rapidly.
Yeah.
And a lot of times what we're doing in the state is following Medicare.
Yeah.
Could we then add some non-binding language that states that, that will consider other methodologies as technologies develop and are accepted by Medicare?
Mm-hmm.
So that we're not so limiting in what we're doing that we have to come back as each technology evolves.
Yeah, I think
so. Dr. Scott, I just found the article by Nate Lackman on the virtual check-in codes that kind of delineates the difference in those. Maybe we can draw from that.
This is from Nate Lackman, you said, and
Yeah.
at CTEL? Okay.
Yeah.
That'd be great. Okay. So I think we'll try to add a slide on telephone only, and it will have suggested codes from CTEL, suggested codes from Cheryl and Brody, and then a notation that this is an emerging field, and that stay tuned as Medicare changes their policy on that. All right, so technology and then patient information data transmission.
We haven't made any changes to the slide since the last time.
Okay.
Same to the website manner section. We did not make any changes.
Yeah. And I like the pictures that you guys included. Those are great. A little bit more about lighting. Denny, this is, or sorry, not Denny, Adam, this is where you and I said there could probably be 50 slides on anti-kickback and Stark laws. We were wondering, right now I think we've got 1, 2, 3 slides on it. And my question to Adam offline was, whether we talk about safe harbors, and I think you can really start to get down to a lot of details and really getting down to brass tacks. We wanted to keep it high level here and just make sure that people know where to go to get a little bit more research. They need to know that this exists, and this is kind of something that need to be in compliance with.
Yeah, I mean, that's my general perspective, is that that there needs to be, for the people taking this or reviewing these slides, they need some awareness of these federal prohibitions that relate to relationships with other referring providers, financial relationships with those providers, how you market your services. So a general awareness, but we're not going to get into real granular detail. I don't think that would be useful for this, for this purpose. So it's kind of just a high level discussion of these federal standards.
Okay.
So is this just to give them the high level, but are there possibilities of inadvertently creating a Stark or I'm thinking, okay, like an ambulatory surgery center, you're self-referring. Could you be building a telemedicine practice and self-referring into that? Is that where you're looking at, or how? I'm trying to get that broad picture.
Yeah, I mean, if I were doing this, first of all, they need to know that this exists, and then if they have any questions, it probably is. This is where they need to consult an attorney.
Okay.
That would be my suggestion. There's enough other details here, safe harbor being one of them, that if you're at all concerned, that would be my recommendation. They, consult the attorney, an expert in this. Do you think that's clear?
We could add, consult your, legal counsel with questions. We could add that. Senator, to kind of give you a sense of where this comes up, one area where the federal government has provided some guidance is when hospitals want to provide free telestroke equipment and services to rural facilities. Is that okay, or is that offer of free equipment and services to a rural hospital an inducement to get them to then refer the stroke patient to the hospital providing the free services? And there are times when that's good and there's times when it's bad, so it's hard to really in a slide deck do that, have that type of discussion and analysis. And for the most part, doing things that are good for patients will be okay from a regulatory perspective, but that's when you really probably should be discussing in a detailed way the arrangement with legal counsel to see, you know, are we interacting with our partners in a way that complies with the Stark law and the anti-kickback law.
I appreciate that. Thank you.
Yeah, there have been about a half dozen OIG papers that have been put out. One of them Adam just referenced. And those are, you know, usually 10, 20-page documents that come out with some kind of it's not an official like law, but it is guidance.
Oh, I know what you're talking about.
Yeah,
I used to get those all the time.
Yeah.
They were,
Office of Inspector
yeah.
General. I mean, they come out with a very specific question, very specific case. And so, you know, you can't say this exactly applies to your situation, but it does give you a little bit of guidance, saying this is similar. So that's the kind of thing that an attorney would point to. Yeah. So I guess my only other thing for the slides would be, you know, if you are concerned about this, you should consult a legal professional for further consultation. Maybe the last bullet point here on 31.
Sure.
Cindy Jacobs, anything else you want to add on this? Have people come to your law school class and become experts? Right, maybe we lost Cindy. Cindy's also an expert on this topic. All right, so malpractice. I think we just have one slide there.
Yes, we made no changes to this from last time. No changes here in the end either.
I like.
And no changes there.
Dr. Scott, one question. I don't know if this has been discussed before. Legal's covered pretty well, but one of the things that we're doing a lot of these days is going through risk and compliance as well. I don't know if Adam has any insights into how we might describe that, because it's getting pretty granular and program specific and location specific and those sorts of things.
You know, gosh, there is so much to say on risk and compliance. One idea would be, you know, we could have like a compliance checklist slide that says, you know, be sure that you're also considering these other areas of compliance, given that healthcare is such a highly regulated field. Make sure these are on your radar and just kind of have a checklist of topics, you know.
Or just add it to the summary checklist at the end, yeah.
Something like that, yeah. Mm-hmm.
Okay.
Yeah, so slide 30, we're looking at slide 34, Adam. Would it be, you know, make sure that your telemedicine practice is in line with your risk management policy and you know, compliance.
Right.
Something like that. We can wordsmith that a little bit, but maybe add at least one more bullet there. Okay. And then I think the last slide here is just all the various references. I'm wondering, Jamie, if we could just make that a font a little bit bigger.
Like a lot bigger.
That would be helpful. And I just want to double check that the NRTRC is at the top there, Deb. And I think there's a national telehealth, like more of a telehealth policy. Do we have that one on there? Deb, do you know what I'm talking about?
Yeah, I can help make sure you have.
It's number 7, isn't it?
You're talking about the Center for Connected Health and Health Policy.
Yeah, there it is. Yeah, number 7. Sorry.
Yeah, it's number 7.
Yeah, and you've got the one at the bottom, the fact sheet. I can see the one you have for the NRTRC is we're getting closer to launching a new website, and that I can see that's on the.
Yeah, that's first one.
it's the development website. It's not the live website. So maybe we can work to do that.
Okay.
Make sure we have current links there.
Great. Any other comments or suggestions on the training deck? Danny had brought up go ahead. Go ahead, Dr.
Can you go back to? Oh, doctor, I don't got that kind of education.
Representative Chili.
Can you go back to 34? Yeah, 34, please. I just think that there's a lot of interest around, you know, a checklist. I think particularly with folks who are kind of uncertain about using telehealth and technology. And so I just think this is great. And I think anything we can do to come up with some model checklists, kind of standard checklists that could be jumping off points for a lot of organizations would be really great. So I really appreciate this is in there. And I think you could probably, you know, add and make a whole bunch of different points. But if we can put forward something that generally is agreed to is like, this is like your jumping off point, I think that's fantastic. It seems like there's a lot of uncertainty. And when I've worked with providers, they want something in front of them, at least it covers their basics. So.
And Representative Riccelli, do you think there's anything that's missing from that checklist?
I do think there's stuff missing, but I think then you just get into this snowball of different, you know, like if you were with behavioral health providers, you'd want to say like, well, do you have your number to call us? You know, like if it was an emergency situation, et cetera, all these different things. You know, in a practice, you'd want to know like, what's the front office number if we get cut off or things like that. But I think boiling it down, there's probably one or two more. I just think it's worth exploring more and maybe building, but not creating like this huge laundry list, but saying here's the basics. But I don't necessarily see anything right now that should be added. I'm sure there's a couple points, but probably out of my range to come up with those.
Okay.
This is Joelle. When I was reviewing this slide, I was thinking more about sort of readiness to engage in telehealth services, and that it could even be subsectioned out into categories depending on what types of services. So sort of the global services, but maybe even depending on licensure versus health systems. You know, we could think about categorizing these areas so that people could go to those. Maybe people are already up and running, but they want to sort of run a checklist on, well, do I have all my ducks in a row versus someone who's doing a startup? You know, it's their first experience. It's getting a little bit more into the weeds, but if the intent of the checklist is to help providers and individuals who are engaging in telehealth make sure that they're hitting all of their key areas, we could probably make this a little more user-friendly.
Yeah.
Yeah, I think the only other one that I would say, you know, would be like, what happens if we get cut off? Like, you have a plan, like something like that being on the checklist, like
consent stuff. Yeah.
If it's cut off, yeah.
Dr. Scott, any thoughts about data collection for program assessment analysis, you know, all those sorts of things? I know it's a big topic, but.
Yeah, you know, I don't think that's a requirement, Denny. I mean, I think it's again, I'm guided by Senator Becker's question is how do we keep the doctors out of trouble? You know, and so I want to like make sure that everything on that list is, you know, for the most part, keep the docs out of trouble. Make sure they're using the technology, they're HIPAA compliant, they're actually, you know, got licensure in the right state. You know, they're not doing any of the Stark or anti-kickback stuff. Yeah, so.
If I were to add one thing, it would be the malpractice to this checklist.
Yep.
Just so that they know they should check with their malpractice carrier.
I think that's a great one. Check with your malpractice carrier.
But I think that, and from my perspective, I want docs and providers to want to come on and do telemedicine. And if we're not careful, we're going to scare them out of doing telemedicine with too much detail on this. The detail should come from the rest of the training.
Yeah. And I think to go back to Representative Riccelli's question about like, what do you do if there's a problem with the equipment? I think maybe we have that in here. Welcome patient, introduce yourself and provide an explanation of the procedure and equipment. And we could almost add maybe another line here and how they would contact you if there's any problem with the equipment. So that's slide 25. Yeah, that's a real essential. All right, so I think we maybe got one or two more things here on the summary checklist, adding the malpractice statement. And then there also was making sure you're checked with your risk management folks and compliance folks.
This is Deb LaMarche from the NRTRC. I just want to congratulate you on an amazing document. And I think the discussion that you're getting into now about wanting to provide the detail and not wanting to scare people off is really kind of the crux of what we go through when we're trying to bring people onto telehealth. So I actually like how you've done this, where the summary checklist is pretty high level. Yes, maybe you add one or two things, but that looks manageable. Then you've got all the detail and links to more detail. It's just very well done, and just wanted to congratulate you on the work that you've put into this. It's really great.
Thanks, Deb. Oh. And this will be public, so people can, if there are other folks on the West Coast who want to use this in your region. It'll be Washington specific, but hopefully will be useful for other people.
Well, when we launch our new website, we're going to have a section for each state, and one of the things we want to link to is to the collaborative or whatever type group like you have in each state, and there'll be an opportunity for people in that state to have links on the state page that go to whatever you want.
Great.
So make sure the credit stays where credit's due.
I wanted to come back to a question that Danny raised about e-consults. Danny, do you think we need to include a slide on that?
Maybe take a look at that document I emailed you, Dr. Scott, and see if you want to include the check-in types of things at Medicare, or just keep it in the Medicare section.
Okay. So sounds like we're about 95% there. Maybe just a little bit more tune-up. We'll make those tweaks. I'm going to hope to get that out in the next 1 to 2 weeks, and then people have time to look at it ahead of time for our next meeting. And so I was wondering if we could check in about some of the certification and getting like CME credit. This is something that Joelle has done quite a bit of investigating on. And so I wanted to turn it over to you, Joelle. And what I'm going to do, Joelle, is pull up your email that you had sent to me. So as you're talking, people can read what you learned from your colleagues at the WSNA.
Oh, sure. So one of my roles at the WSNA is to run our education, and so I'm very familiar with it. And I did sit down with the executive director and then also our education director about the possibility of loading this training module on the learning management system at WSNA, which is accessible by a website anywhere you are in the country or around the world. We do have a learning management system there. Just to give you a little bit of background information, any learning management system has a couple different parties that are involved. One is that it's a platform that is essentially administered by a third party who helps maintain your learning management system, does all the annual updates, and kind of keeps the system running in the background. then you often have a third-party administrator who helps you load content, take content down, help users when they're having difficulty getting into the system, forgot their login passes, user IDs, etc. So, so it's a legitimate learning management system that also has the capability of providing a certificate of attendance. Now, we talked about continuing education. We do provide nursing education credits that are accredited through national nursing bodies. That is a lot of work, and in order to do that for all the other accrediting bodies for all the other disciplines in healthcare would be impossible for WSNA. Now, this has the capability to have some interactive learning modules, including perhaps interim question and answer, sort of little mini quizzes, if you will, or a test at the end to demonstrate some knowledge that they've accrued, which is sort of a legitimate approach if we want this to be a true learning education module. And so there are different ways that you could administer it. I did review the content with the education director who has a doctorate in education, and one of her recommendations was that if we were to move forward with this, to really make it a little bit more visually appealing and more consistent with the learning experience and the learning environment, which would not be difficult. Sarah graciously accepted an invitation to narrate the slide deck if and when we get to that point. Now, one thing you need to know is that these third-party entities do cost money to anyone who manages or who has a learning management system. So that's one of the major considerations here is if the collaborative would be accepting of a $25 charge to any participant who comes to the table. So the $25 covers the user fee that is charged to each individual user to WSNA. And it also covers the administrative fee for that third-party entity who manages all the content, all the data, the stats, and the users, help support the users when they come to the environment. So that's sort of a high-level introduction to what it means to load content on a learning management system. And that's at the Washington State Nurses Association. Now, I did want to tell you that one of my to-dos was to discuss this also with the Executive Director of the Nursing Quality Assurance Commission, Paula Meyer, and she was very supportive of this. They do not have a learning management system. They could post a slide deck at their website for access to the public, but there would not be any sort of live interactive education element to that. So I'll kind of leave it there and open it up for questions.
Thanks, Joelle. So let me just clarify. So the WSNA is willing to run the learning management system, which is kind of like an online kind of portal, and we do them all the time for compliance training for $25 per user.
Mm-hmm. That's right.
Wow, that sounds like a really good deal.
If that user comes back to the learning management system within a calendar year, it actually does not charge the WSNA. It's per user per year. So if they come back to do other education modules, then we don't get charged for that. But if the user comes once in a calendar year, then we get charged on the back end for those users. So, I can tell you that I have intimate experience with the University of Washington School of Nursing Education. They have a very robust education platform, and it's very expensive, including we'll use their suicide prevention training as a, suicide prevention training is mandated for healthcare providers in the state of Washington. And their training modules for the users are costing the upwards of $200. And so, if you consider what education costs for providers in pharmacy, medicine, nursing, et cetera, it runs anywhere from about $15 to $45 per credit hour. And I think we definitely have enough content here to do a 45-minute or 50-minute education module with a 10-minute test. And that would be the equivalent of, we could provide a certificate of attendance for 1 hour of continuing education. So some licensures require an accredited accrediting body to accredit that education to count towards their relicensure, and some don't. They just need a certificate of attendance. So it depends. But the education director would definitely help give a little more advice to sort of make it a more a pleasurable learning experience, so that it's actually like a live learning module, but also created in a way that it could be easily updated as the landscape changes.
That's great. Senator Becker had a question for you, Joelle.
So I have a question regarding the $25 fee. Would we then, are you picturing that we would collect that at the state and send it to you? Would you be collecting that? And what type of providers would be able to access this through the WSNA?
Anybody could come to that learning environment. There would be nothing to limit. It could be my 16-year-old son. It could be my 80-year-old mother-in-law. It could be anyone. And the learning management system actually has it has a checkout center. So the individuals would pay themselves. There would be no transaction at the state level.
Thank you.
I mean, that sounds like not an onerous amount of money.
Oh,
and
no,
I mean, you can see it's 34 slides. Probably would take, imagine, 40 minutes to go through it. So, Joelle, you mentioned the UW and their CME, and this is something that Carl Tal helped to pull up for me. And just confirming that the UW is pretty expensive. So just to have an annual CME event, something like this is anywhere from $650 to $1,200. And if it's an enduring internet activity, it can be as much as $7,000. And then for each credit, they have the person then on top of that would have to pay between $25 to $100 to $65. So this sounds like a way better deal.
Sounds like a way better deal. But then the next question is, you said that some of the carriers will, or not carriers, but some of the groups will accept it as accounting towards their CMEs and others won't. Right. Can you clarify that?
Yeah, I'll give you an example. Yeah, so I'll give you an example as a nurse practitioner. When I recertify as my board certification on a national level, I need to have so many credits, proof of credits that are accredited by the American Academy of Nurse Practitioners or one of these entities, the American Nurses Association. But actually my license in the state of Washington does not require that. So when I relicense in the state, I have to have so many hours, but they don't need to be necessarily accredited. I can just have a certificate of attendance that I went to a medical conference or a nursing conference. Now, each licensing body and board certifying body have different requirements. So the reason why this is a consideration is that getting a certificate of attendance or an accredited hour of continuing education is more of a driver for people to actually engage in that learning experience. However, if this is state mandated, if that, your legislation goes through, getting a certificate of attendance for people will be great, but it's not really realistic. Like, in order to provide an accredited hour of credit with all these licensing bodies or accrediting bodies, it's just not realistic. It is a massive undertaking and it's very expensive. And there's a lot of data that has to be uploaded and reported to these national certifying bodies. So just to kind of give you that background, in consideration, like the Medical Quality Assurance Commission or WISMA, et cetera. This is the reason why people are getting out of being providers of education, because it's not easy. It's very time consuming and resource intensive. Did I answer your question?
You did, thank you.
Now, I want to make it clear, WSNA, the Nursing Association, the $25 does not include, it's no profit margin. It is just to cover the administrative cost of having that content on the learning management system and supporting the users as each user comes to the environment.
Joelle, is there any cost to build it?
WSNA is willing to provide the people hours, the support. I could help with that, developing it to be more visually appealing. That would be on my own time. And then the education director offered to review the material and support that development, including a quality recording before we push it off to the administrators that would get it loaded on the system.
That's fantastic. I mean, I think that's an amazing amount of support provided by WSNA. So I mean, I don't know if we need to vote on this, but I would propose that this be the way we go forward to make the training widely available around the state.
Agreed.
Yeah.
Agreed.
Yeah. Anyone feel strongly not doing this?
Now, just to clarify, that is unless your system has their own training available, correct? So this is for folks who don't.
Correct.
Okay. Thank you.
Well, great.
Well, and I think that we're prudent. I think the exciting piece after reviewing this bill that Senator Becker is drawing up, we're ahead of the game, right? The content is amazing. It's very comprehensive and would most definitely qualify for an education system and would be really ready to go if this legislation pushes through. So I think it's just wonderful and very timely. And in terms of timeline, I think that it's realistic given WSNA, like we're getting ready to host a very large convention in May, but I think it's realistic that we could have this in the live environment within the next 12 to 16 weeks.
That's great. Wow. Thank you. Joelle, is there anything formal we need to do? I mean, is there like a MOU or anything we need to sign, or we just kind of go ahead and do it?
Yeah. The next steps would be for us to finalize our slide deck and get sign off from the collaborative. Then, on the back end, we have to consider how we're going to create a more visually friendly and learning appealing platform. That includes getting really some more pictures and different visuals that are within that fair use copyright bandwidth. That would take some work for myself and for my colleagues at WSNA, and then getting Sarah to record it. So it's just, we could do that.
Okay.
Question for her.
Yeah.
So Stafford just brought this up in the bill that we're putting forward. It says may be available in electronic format and completed over the internet. If the training is provided in electronic format, the provider of the electronic training must provide a question and answer methodology.
Yeah,
will that interfere with?
Yeah. Oh no, the learning management system, that's what it's totally capable of doing, because
perfect.
Theoretically, when you're providing education that's accredited, for example, you really have to demonstrate some level of knowledge that they actually learned. And so we definitely have the capability of building in a test, if you will, throughout or at the end. You can build in questions as they go through. So they could get through a couple slides on a certain topic, and then a question could come up and say, could test their knowledge. And then you can have like 10 questions at the end.
Okay, thank you.
So Joelle, I'd be happy to craft those questions with you. And then also we have experience at UW of doing those voiceovers with the PowerPoint. We have a high quality microphone and quiet recording place. So I'd be happy to coordinate with you and Sarah to get that time set up.
That'd be awesome. The major deal, John, is to just make sure that it's in a format that the third-party vendor can actually, that's compatible with the learning management system to upload. But great. Okay, we'll just continue to march right along.
Yeah. I don't know if it's JPEG or there's actually a way to tag audio with the PowerPoint. So
yeah.
This is great. Thanks everyone for all your help. This really truly was a team effort. So this is hopefully will benefit a lot of people. Unless there's other questions or comments on that, maybe we can move on to the next topic.
I just want to make a comment. When we envisioned this collaborative and we had all those people apply, and I kept thinking we have some of the greatest minds in Washington State working on this. This goes to prove that that's really true, and I'm really excited. I'm excited about this training component. So thank you so much. Yeah.
I think we need to especially thank Sarah, Sarah Orth, who's done a lot of heavy lifting, and Adam in the last month. So thank you guys. All right. Well, the next thing on our agenda is to talk about the NRTRC conference, and I had asked Cara Towell to give an overview. Cara, are you on the line? And Cara, if you're not, maybe I can put Deb on the spot.
I am on the line.
Okay,
Can you
good.
hear me? Sorry about
go
that.
ahead.
I have to double unmute. Yes, I'm here, and I hope you don't all mind, but I did invite Deb LaMarche to come and talk because I think she could really give us a great overview of the conference. I can give you an overview, a sort of overview of how wonderful it was, but Deb and her staff really did all the work in putting it together and tracking it. And I think she sent a slide, and I sent some information also to Jamie that was basically just an overview of the schedule of the conference. And I don't know if you're able to post that. I think Jamie shared it earlier. But it's a great. I will just start out by saying it was a great conference. It starts out with a half day of Telehealth 101 and 102, which is a really great program for people who are just getting into or are fairly new into telehealth. And then the second 2 days are a combination of more how-tos, about legal issues or technical issues or things like that, as well as sort of a show and tell opportunity for people to let us know what they're doing in the region. It's also a great opportunity to get to know the people in our region. The ATA, big telemedicine conference every year, is fantastic to see everything and see people from across the nation, but this is a really nice opportunity for people to meet people within the Pacific Northwest, including Utah, to find out what's going on and find opportunities for collaboration. So I'll leave it at that and turn it over to Deb to talk more in detail.
Thanks, Cara. Deb, do you want to elaborate a little bit more?
Yeah, I will. I'll just say, prior to this conference in the fall, here in Salt Lake, the previous 3 years, the NRTRC had their conference in Seattle. And I can tell you, you'd set a really high bar. And it had been really impressive. We decided that we wanted to start moving the conference around the region. One of the things we learned really early on is not a lot of people have budgets to travel to conferences anymore. I mean, some do, but a lot don't. And so we thought if we could move the conference around from state to state, we would be able to attract more people. So that's what we're doing for now. We streamlined it a little bit. More of it was single track rather than the multiple tracks the NRTRC had before, to be manageable. In some cases, we did go to dual tracks just because we had a lot of content. And some of the few complaints about the conference is that they couldn't participate in the sessions when it was a dual track. They wanted to participate in both. The poster sessions we added, and they were very well received. Cara talked about the opportunity for collaboration, and one of the very cool things about the Northwest region is just the amount of innovation and fantastic projects, and the people that have been involved in telehealth for a long time. And we wanted the opportunity to foster the opportunity to meet people and find colleagues in other states. One of the challenges we had and was providing a conference that offered good content for experienced telehealth people, mostly from academic medical centers and health systems, as well as offered things for those maybe newer to telehealth, the federally qualified health centers, critical access hospitals, public health. So we did our best to strike that balance. We did have some Washington State presenters. Dr. Danielle Dolezal, did I butcher her name? Probably. From Seattle Children's. She gave a fantastic presentation. Tammy Arndt from Northwest Telehealth had a session that was really on some practical tips. And Cara Tal, who was also on our planning committee, was on a panel of board members talking about what was happening in their states. We did post presentations on the website, except for a few, and Dr. Dolezal's was one of them because it's part of a research project, and she was providing research data that really wasn't ready for publication. So, but most of the presentations can be found there. Next year, the conference is in Anchorage, August 28th to 30th. We will have the request for abstracts for presentations and posters will be sent out very soon. We're just doing a little coordination with our conference management team. When that goes out, I'd ask you to share that with others and consider. I mean, I think a fantastic presentation is what we are doing as a state for training. I mean, that would make a fantastic presentation in itself. So think about things that you might want to share with the region. And late August in Anchorage, we can be in worse places. So I don't know. We welcome input. So any ideas people have for ways to improve the conference, we'd love to get that input.
Great. Thanks, Deb. You mentioned the cost of the conference. It used to be about $200. Is that still the cost for registration?
Yeah, we keep that down. But what we're finding is that that's not the deterrent as much as the travel costs and lodging. And I mean, it was just really interesting. We were at different meetings. We were in one meeting in Montana, and there were some telemedicine program directors that didn't have money to travel across the state for a conference. And so it's just, so we're looking at, we still think there's value in the conference. Our conference isn't gigantic. We had about 150 participants, and I think it was very worthwhile, but we have to supplement that with a lot of other training opportunities and other things that are closer to home for people.
That's great. Just so folks know, that conference is about a fourth of what the national ATA conference is, around 700 or 800. So that's quite a bit cheaper, and I think Anchorage is cheaper than New Orleans, at least last time I checked. And it's a 2-day conference, right?
Yeah,
From
well,
Monday,
it ends
Tuesday.
up being, it kind of ends up being 2 half days on either end and a full day in the middle.
Okay.
So you can come on a Wednesday morning and fly home on a Friday. We are considering changing the pre-conference workshop the first day from a half day into a whole day, because that was really packed, and we may just want to offer more, and it's an optional part of the conference. So
Great.
It may end up being 2.5 days.
Thanks, Deb. One last plug. I want to.
So I was just going to say, there was a question. Lisa asked if you can attend the conference virtually, and so far we have not been able to offer that. And I think it has more to do with the complications of the technical issues. Is that right, Deb?
Yeah, it is. When you go to hotels, no matter how good they are with what they say their broadband is, it's just a little sketchy, and so we haven't gone that far yet. We are going to take some of the more popular sessions though and make webinars out of them to repeat them.
That'd be great. One advantage of having the meeting in Anchorage is that is the location for the National Technical Resource Center.
Yeah.
So if you have technical questions like, should I go with this platform or that platform, or if you want to test out some peripherals and things like that, I imagine the folks from AFCAN and the National Technical Resource Center will be there, right?
Yes. In fact, thank you. That's big. TTAC is co-sponsoring the conference with us, so they will have a good training session on the pre-conference day, but they'll be there the whole time. And so you're exactly right.
Yeah, so that's a real unique advantage of where it is this coming year. Well, great. Thank you so much, Cara and Deb, and I really appreciate that update.
Can I just throw out one more thing?
Yeah.
We'll be at the Northwest Rural Health Conference. That's going to be held March 25th to 27th at CTAC. And I'm actually hoping that I can use that week to spend some time in Seattle or the greater Seattle, Tacoma area and meet some of you in person and see what you do. So we'll be working to make those arrangements, but we'd love the chance to meet you in person.
Great. Remind me when that is again, Deb, that you're going to be in Seattle?
It's going to be at CTAC, March 25th to 27th.
Okay.
Maybe we should change the collaborative meeting to CTAC and have it during that.
Yeah, we'll.
Yeah.
That's. I don't know if folks heard the suggestion was maybe we push the March meeting a couple days later to accommodate Deb meeting us in person and try to do it around the CTAC area. We'll definitely look into that.
I also wonder, John, if the collaborative is involved in that meeting that's being held there. It's the Northwest Rural Health, the one that's usually held in Spokane, but this year they're holding it in CTAC. And I think that might be something nice that we could piggyback onto to sort of, expose a lot of rural folks who attend that meeting to telemedicine.
Yeah. Is there any way that either you or Deb could introduce us to the organizers and I can give?
Sure.
Yeah, we can. And I think we will. We're going to be doing a pre-conference training day. We might be able to coordinate a little bit. I mean, we could coordinate with you, or at least make sure that this resource you've developed is highlighted. But I think we'll probably also have a conference booth, and we could have collaborative material there too. I mean, we'd be happy to share that with you.
Great.
That makes sense.
Great. Thanks so much. Those are great ideas, and we will follow up on that. So the next item on our agenda is for Stafford and Senator Becker to review some of the bills. Let me just pull those up, guys, but I'll turn the floor over to you.
There's 3 bills making its way down that we've been discussing here at the collaborative. 2 of them are in your training packets. I received feedback from a few of you, and I want to say thank you for that. The comments have been very valuable, and also the comments from our last collaborative meeting were also valuable. The first one we discussed at the last meeting, and there wasn't too much of an objection, and that deals with adding credentialing in addition to privileging in the hospital communication for telehealth. So one hospital can rely on another hospital's privileges currently, but it adds relying on their credentialing as well.
So this is, it starts with an act relating to physician credentialing and telehealth services?
Correct, and it's the longer one, stapled, but it's amending the bill, so it's fewer changes.
Okay.
And the changes are found on page 3 and page 4, and they're marked in red.
Okay, really just adds credentials and.
Right.
Yeah.
Pretty simple.
Okay.
The second bill is also in your packet that I want to talk about, and it's the one-page back and front document. It deals with training, telehealth training, and this is a new section, so this will all be new. And I can start by presenting some of the changes that were made from the one that was last time. You'll see that it's a couple pages shorter and simpler. It added a purpose or intent section there at the beginning. That's the first paragraph. Another change is that we added telemedicine as defined in RCW 7041-020, but the word there is actually telemedicine, not telehealth. So I changed telehealth to telemedicine throughout, just a technical change. It includes the basic training that must be provided, and note that the language of that slightly changed too. It includes specific things that need to be trained on, but it also includes Department of Health, which was in it before, but it includes Washington Medical Commission, specifically at the Department of Health.
Okay.
And then in conjunction with the Telehealth Collaborative. Those are for additional topics that would need to be trained on. And that's paragraph A on the back page.
Yeah, I think the official name, Stafford, is the Washington Medical Quality Assurance Commission, unless they've changed it. I know they're in the
MQAC, yeah.
MQAC, yeah.
Right.
I know they're eventually going to shorten it to just the Medical Commission, but right now I think it's still MQAC.
Yeah.
Okay, do you want me to reach out to Micah and ask?
Yeah, just double check whether that name change has gone through or what's the right name.
Okay.
So he's had opportunity to look at the view and talk to you about it.
Yeah, and these incorporate his changes, one of which I was going to talk about next, and also other comments were along these lines. And it removed the form, acknowledgement and understanding form, and rather just changed it to attesting to knowledge and understanding of the training, which appears to be more in line and consistent with the industry.
Good. So you don't have to pull out your certificate or anything like that.
Right.
But if anyone ever came and said, hey, you're doing telemedicine, did you get trained? You'd have to go back and say, yes, I did. Here's my online.
And here's my attestation statement.
Yeah.
Yeah, and the enforcement teeth that were in it before were taken out, and it's going to be done more through general inspection.
Okay.
Rather than a specific arm that would enforce this. There was a paragraph added concerning health systems or other organizations that currently have a training that it just specifically instructs that they can continue doing their training. They don't have to do an outside training.
I think that was Denny's question.
Stafford, this is Joelle. Really quick, do we need to define within the institutions that they also need to adhere to a question and answer methodology?
Yeah, and that was another change. You'll find paragraph B, 3B on the back with what Senator Becker talked about earlier, that if the training is provided in electronic format, there needs to be a question and answer methodology. Are you proposing to have the question and answer methodology and regardless of if it's electronic or not?
Well, that's a great question. From an education standpoint, honestly, if you're truly doing some level of education and learning is involved, you have to ask yourself what the return demonstration that they've accrued the knowledge, the intended knowledge is. That can be in a written format, that can be in a return demonstration in terms of skills. So I would just say, if you're talking about education, directly about education and imparting knowledge, which I think is the intent here, whether it's online or in-person training, we have to ask ourselves how the learners are going to demonstrate that they actually accrued that knowledge. And that could also be through a 10-question and answer test. That would be standard. And when we're talking about any kind of hospital-based training, competency training, it usually includes a question and answer or a return demonstration of skills. And in this case, it's knowledge that we're looking for. And so the question and answer is the appropriate means for that. I don't know if anybody else has something to comment about, but that's in the education world, when you're dealing with adult learners,
that's the standard.
Yeah, I totally agree.
Okay. A proposed change that I'll talk to Senator Becker and we'll consider is putting that question and answer methodology for all training, not just
Correct.
an electronic format.
And you can qualify it, Stafford, by saying, question and answer methodology to demonstrate knowledge, accrued knowledge. I mean, that's the rationale. That's the purpose.
Say that again, Joelle. The electronic training must.
The in-person or electronic training must include a question and answer methodology to demonstrate accrual of knowledge, of intended knowledge.
I think I'll just put all training rather than specify.
Okay. Okay.
And I can help you with that language, Stafford. Just email me if you need help. Thanks.
Okay, I'll make that change and get it to you, Joelle, and have you look at it. And the last change was that the training and attesting to the understanding is to be completed every 4 years. I think it was 3 in the previous draft.
Yeah, that goes in line with our recertification. We have to get our licenses renewed every 2 years. So that, I mean, every 3rd years would really make it confusing. So I think that's a good cadence. Yeah, I mean, things won't change that quickly in 2 years, but in 4 years, you can anticipate there being a lot of new laws. So I think that's a good cadence.
So, Stafford, the one thing that we want to make sure of is session starts on the 14th. And I want to have these on the first day so I can gather signatures. So what time frame are we looking at for code revisers right now? Because we can write this, but it goes to the code reviser.
Seems like it's pretty.
And any additional comments, it would be appreciated if you could have those to me by Monday, because then I could get a draft Tuesday morning, and that would give them
plenty of time.
3 or 4 days. I don't imagine it would take longer than that.
I think we're 97.
Stafford, this is Denny. I'm just wondering if it would be possible to see your revised language to be able to share it with our leadership and make sure they don't have any questions, concerns. So right now I can give them the general discussion, but it would be nice to see the language if possible.
Yeah, are you talking about the changes after today or the one we're talking about today?
The ones you're going to make after today, yeah.
Okay. Yeah, I can. Do you want me to just send that? Do you want me to just send that to you?
Why don't you send it around to everyone? You can copy Jamie.
Or you can send it to me and I'll share with everybody.
Okay, I'll send it to Jamie and have her.
Thank you.
Yeah.
I'm just worried that I want to make sure we get it fairly cemented. We can, as a bill progresses through, we can make changes. But I want to make sure I have it so I can get signatures that first day.
Yeah, this is look from my perspective looks really close. I mean, there might be a couple words here and there, but
perfect.
Yeah.
So if you have any other additional comments, please email me. Jamie has my email. If you don't have mine for that bill. And any other questions on that before we move on to the next bill?
This is Tracy.
In terms of
Oh boy. This is Tracy Drake from the Department of Health, and I have a question. So it looks like you took some teeth out of this, and what I'm wondering is this requirement that it's completed every 4 years, is that something that you're going to want the department to audit on, or is that something you just want to say it needs to be done, and if somebody wants to question it, they have that proof to provide it, or is this something that will be part of continuing education audit?
This is Senator Becker. If I had my druther, it'd be the latter. Because if you have to audit, we've increased the cost. And if you request it, then they have to prove it.
So you would like the Department of Health to audit as part of
No.
continuing education, or you would not?
No.
Okay.
No, I don't want to increase the cost.
Okay, that's wonderful. Thank you.
And this is Lori Wakashige. I just had a question also about the every 4 years. Can that be in a modified form? Is that pretty open?
Meaning you'd have to do the LMS every 4 years. Lori, I'm not totally understanding your question.
Oh, could we modify the training if they were going to redo it every 4 years, or would it have to be the exact same training that was done initially?
I think if like Legacy already has its training, one would expect that the training is going to change in 4 years. Yeah, and you're going to just be new Medicare, Medicaid laws. So I fully would expect that that's part of the modified training.
And that's included in here with the Department of Health and whoever, and the collaborative to come up with that training.
Okay.
Or those changes. Too.
Okay. So Lori, did you hear that Senator Becker said that that as part of the collaborative work that modifications to the training would be included on the LMS. So you could, as a health system, you'd be able to see what the new changes are and just, you could really just copy and paste and put in your own training.
Oh, okay. Okay, got it. Great. Thank you.
Yeah.
This is Joelle, really quickly. So in the spirit of the suicide prevention training mandated education, there are vendors that have been specifically authorized by the state to administer this information. And so that's a consideration in terms of designating, having the state or each licensing body designate specific vendors. I think it's a quality assurance issue, right? I would certainly trust that Providence Health System is going to follow this mandate and they're going to deliver sound information. But how do we make sure that people are actually getting the information that they need that's accurate? And Stafford, I don't know if you reviewed that bill for the suicide prevention training that was mandated a couple of years ago, but that might be something that we need to take a look at or have a little bit of language about to drive quality.
Are you talking about the Department of Health having a approved list of vendors?
Exactly.
Okay. And that was in the bill in the last draft, and it was discussed at the last meeting, and the consensus was that it would add cost to the bill, to the Department of Health, and that the training, the PowerPoint that is going to be made available that we just reviewed was going to be there. And so there's considerations to be made, but I think the consensus from the last meeting was to not have an approved list for those reasons. Any other thoughts or comments?
Yeah.
Yeah, I guess the question is, how do we ensure quality in the content and the people who are offering it?
Well, I think that's part of the regular activities of MQAC, right? If there are patient complaints, they get them fielded that way with telemedicine or regular. And then if there's, the other reporters are the health systems and colleagues. So I basically would, Joelle, we have to rely on the usual mechanisms for reporting rogue providers.
Sure.
Yeah.
And the one last thing I wanted to bring up too before we move on from this bill is the begin date of when you need to have the training done if you're providing telehealth training. I put January 1, 2022 in here, but understand that's kind of far out.
2020?
We could do earlier, and I think the idea was to have it so far out because, again, the last bill had more requirements of getting a form ready, and it was more formal with the training, but I think we could move that up to January 1, 2021 or
2020.
Especially if we can get it done in 16 weeks.
Yeah.
If we can get it done in 16 weeks in 2020, if we can't get it done, we can always do a bill to extend it.
Yeah. Let's shoot for 2020.
Okay, January 1, 2020.
Yeah. That's reasonable.
This is Tracy Drake. I have a question. If this legislation will require rule writing, are we expecting that the professions that do perform telemedicine will put this in rule as well, that it's a requirement? Then rule writing can take up to 1.5 years.
What rule writing are you anticipating?
And I guess that's my question, is that something that will need to be put in rule for each individual profession? Are we just broadly saying this law is now in effect and people will need to know it's there? Will it be something that will need to be in the profession's rules?
Evan?
The way the bill's currently drafted, there's no requirements for rulemaking. So I don't know if the professions themselves would have authority to draft rules, but this bill would, in this specific regard, this bill wouldn't require any specific rulemaking. The one consideration that might be worth taking into account is, so if this bill were to pass sometime in the March to April to May timeframe, it would take effect 90 days after the fact. So it would become law sometime in the middle of the summer. And so if this requirement took effect January 1st, 2020, the question would be whether or not there would be enough time for all providers to take the training prior to that January 1st date, because the way the bill's structured on that date, if they don't have the training, they wouldn't be able to provide telemedicine services. So that's just a consideration in terms of the actual timeline for implementation.
I think that's a really good point. And, you know, it might be okay for systems, health systems, but when you're trying to attract those outside providers, I think it's a really valid point. And I think that maybe we ought to leave the time frame. That doesn't mean that they can't become certified or take the training and start practicing, but those...
And it's certainly in terms of, you know, the once every 4 years requirement, I could take a look at the language from Stafford, but I think the way that it's crafted, it would allow for if a provider were to take the training at the end of 2019, that it would still begin that 4-year window, so that come January 1st, 2021 or 2022, when the requirement takes effect, they don't have to retake the training or anything. They would still have, you know, 2-3 more years before they would have to take it again.
Yeah.
That's the intent.
As to Senator Becker's point.
Okay. So maybe we'll leave it in at 2022.
Yeah.
Okay, for that reason.
I think,
why not consider 2021? I mean, 1 year for all providers to come into
Year and a half.
Well, a year and a half, really, because if it goes into law in July,
Exactly.
I think that's adequate.
I do too.
We could do like July 1st, 2021.
well,
In 2 years.
So may I comment as a physician leader?
Thank you.
Hi, Mark Mariani here. It's critical when you're leading large groups of physicians from a health system perspective that there is some rationale to when things are required. So reference on the 4-year or 2-year cycle, John. We have to think about how do physicians keep this organized, or other providers? I get really concerned when there's multiple requirements. So this doesn't mean we shouldn't do this, of course, but just think about so it's July versus January. It should be in a cadence that is already being used.
right.
In that sense, we already have the opioid rules that are coming out there. Everyone's trying to adjust to the suicide. We have to think about what we're putting on people as we plan this.
You know, that's a good point. With license renewal, whatever year, may be a better way to do it, just to have it in line, just to keep track of it.
But there's different medical doctors have different regulations around license renewal than others. So
I don't know what the solution is. I'm just calling out
Yeah.
how do we make it successful?
I think if we keep it generic, but I really do have a concern that if we shorten it up too tightly, that we need to attract the individual providers out in the rural communities so that this is really going to do what we want it to do.
The nice thing about the 4-year cadence as well is that depending on when they actually get the education, it may fall at a certain position of their relicensure. So say they just license, they don't have to relicense for another year. Well, then that 2-year will still keep them within the window for their next license. Yeah. So that 4-year actually accommodates no matter where they fall in their relicensure, their annual or every other year renewal of their license.
Yeah. It's not calendar year. It's usually on your birthday.
Right. Right.
So it's going to vary from position to position.
Same with nursing.
Yeah.
Yeah.
It should be the way the bill is currently structured as well. It's not tied to licensure, so so this isn't a condition of licensure.
Yeah.
Right.
Necessarily. So you could still get your license on your normal cadence regardless of this additional training.
stick with 2022.
I think we should.
January 1st, yeah. That gives us a lead time. I think more people think about laws going into effect on the first of the year than the middle of the year. So that'd be my suggestion.
Okay, let's just leave. Did you?
No, I'm good.
Okay.
Who would have thought the calendars?
Yeah.
I knew it was going to be January 1, 2022 from the beginning. That's why I put it there.
But it was worth the discussion.
Stafford, did you want to go to the third bill?
Yeah, the third
Oh,
bill we discussed.
wait, sorry, about the attestation. So is the Department of Health going to be responsible for collecting the attestations? We talked about a form online. Is that right? And will it be, I think we should be clear about that. And if they do their training within a health system versus an online format, will they just be directed to that online form at the DOH?
So as we envision it, the Department of Health does not have to collect any of the attestations, but if they do have some kind of a question, then they can request that attestation and the training.
So, I mean, let's get down to brass tacks. If I'm a physician, I want to start doing telemedicine, what I would do is I would have that online attestation form, complete it, print it, and then have the evidence of the training, put it in my files. HR would have this, whoever has the, at UW, we have the medical staff privileges, they would have a copy of that. So,
and as an administrator that did all that sort of thing, it would have all been in there as well, all the attestations, all the training.
And Dr. Scott, I would agree with that. For a health system that has hundreds of providers, many of which are out of state, that's a tremendous administrative burden if it weren't done that way, I would say.
Okay. So you agree with what we're...
And we can build, if we can get that link developed, then we can build that into the online learning module, so that at the conclusion of the education module, it'll say, next steps, you need to download this attestation and submit it to your credentialing okay, great. I think it's just great to have all this operationally figured out. So if questions arise through the legislative process, it just appears that we're totally ready to go.
Okay, so that means that each and every one of you have to come and testify on the bill.
Give us lead time. Great.
Okay.
Okay, the third bill, we didn't talk about it at the last meeting, but I believe we did 2 meetings ago. It has to do with payment parity, and it mainly does 2 things. It requires that telehealth be reimbursed at the same rate as if healthcare service was provided in person by the provider. And the second thing it does is it removes the requirement of an office visit for use of store and forward technology.
And do you want to address the facility? Payment could be negotiated.
Right. And the specific language for that is reimbursement for a facility fee must be subject to a negotiated agreement between the originating site and the health carrier.
Sorry, I don't have a copy of that.
That I didn't provide a copy here for this one, we've discussed it before, but I'll send a copy of all 3 of these to Jamie once I make these changes, and she can send those out. And then by Monday, hopefully you can get comments to me if you have any more, so we can get it ready for the 14th.
And did that have any provision for unless a carrier has a negotiated plan with you?
In what part, Denny? We did it for the facility portion of it to where it was all negotiable.
Okay.
Just like today.
Okay. I think I follow you.
Has the parity bill been run by a whip?
We presented the parity bill a number of meetings ago and we wanted feedback on the parity bill. And we got no response. So we are assuming that the parity bill is pretty ready to go. And hopefully we don't get a surprise going into session.
if there's, I would recommend some sort of follow-up. I'd be happy to help do that and try to get more proactive feedback for you. Or if you wanted to reach out to them directly, that might be a good idea.
Well, we'll send it out to you all.
So AWIP?
Washington Health Plan.
Washington Health Plans, okay. Can we contact you? Because I don't know if I have the email for them.
Yeah.
Okay, great.
Hey, this is Brody. Just Regents did send an email to both Senator Becker and Representative Schmick on November the 29th and have not received any response to those emails.
Well, that's interesting. I haven't seen that, so I don't know why I haven't seen that. Would it have come from you, Brody?
Yes. And I
Brody,
used the emails on the distribution list for the minutes. I don't know if that got lost in the shuffle somewhere.
Brady, would you mind resending that to Jamie and myself?
Sure.
Yep.
And myself
Sure.
as well.
And Senator
Brody,
Becker.
I'm sorry, I didn't
It's okay.
see it.
Okay. Well, the next agenda item is to talk about the state telehealth technical assistance centers. So in the original legislation that created the collaborative, one of the to-do lists was to look at what other states are doing around technical assistance centers and to make a recommendation to legislature whether we should do something like that in Washington State. So I'm just going to share with you what I have learned and what other states are doing. It's a Word document here. Let's see if it's coming through. Sorry, Mike. Okay. So there are about a half dozen states that do have technical resource centers. And they really fall into several categories. Basically, there are states that started this in the 90s, and then states that have started maybe in the last 5 or 10 years. And I think that part of that is related to the technology and how expensive it was up until a couple years ago. So back in the 1990s, you would have to use very expensive servers and routers that would cost millions of dollars. So it just wasn't practical to do something like Zoom like this. You'd have to have that equipment. So that's where, like Arizona was a good example of a technical resource center that started in the mid 90s, and several others that were started. The other thing that I wanted to highlight is that a lot of these statewide technical resource centers are linked to the national TRCs, the technical resource centers, of which Deb and the folks in Utah are part of that. Another example is in Missouri. And the funding is all over the map. So in some cases, there's a line item in the state budget to support these. In New Mexico, it's a private public partnership. So there's basically a lot of the vendors chip in money. I think that having talked to my colleagues in New Mexico, that has been pretty tough model. It's really volunteer and has been harder for them to make any progress on that. A good example is the CTN, of which that's part of the OCHIN family. So I don't know if Mr. Arbaugh wants to say anything more about what CTN is doing. They have a long history, and they do provide some of that technical assistance beyond some of the policy work as well. So that's kind of what I've learned from the states that are out there. There's about, there may be a couple more, but they're all over the country. And, I feel like with having a regional TRC and having the collaborative, where there's a lot of the holes that are being plugged and where traditionally were some of the gaps. Did you have any questions, Senator Becker?
I'm not sure. I have to think about this a little bit, and I'm not sure that I see how we go forward with it in what we're doing. Do we, I just have to think, maybe ask some more questions of you.
Yeah, I think that with the like I said, a lot of these were started when the technology was super expensive, and now with it being so cheap, I'm not sure that traditional need is still, still there.
Okay, so let me go through this in more detail and maybe give you a call.
Okay, sounds good. All right, so our last agenda item is to look at the next meetings. And Jamie, I'm going to turn it over to you. But let me pull out the document.
So this is in a separate document, but it's also in the meeting minutes from our last meeting. I did make note that we were trying to change the March meeting to see if we can get Ms. LaMarche here with us. So I'll get back to everyone unless there's a date now that works better, but that's a Monday through Wednesday. So I'll connect with Ms. LaMarche and see if there's a time that won't interfere with her conference that we could all also accommodate, and get back to the group on that. But what I would like to do is, I guess, just see if, can I propose that this is accepted? And and if so, then we'll just go forward and say this is our schedule. And if we have to accommodate any changes going forward, we'll do that at that time.
Okay.
I might make a suggestion that our late March meeting be in CTAC to sync up with the rural conference and Deb LaMarche. And then I'd like to get down to Vancouver, maybe in May, and Lori has offered to host us. Lori, if you wouldn't mind checking with your room availability and your technical support folks on May 6th to see if that would work.
Okay. Sure.
And then you can see some of the other dates there. We try to rotate this around. If you have not hosted yet, we'd love to have you host. And we do like to get out to Eastern Washington at least once a year to accommodate our colleagues out there. So I don't know if Representative Schmick or Representative Bocelli have any times there that look especially appealing for you to all to host, or I can talk to Jeff Jones and the folks in Gonzaga, see if they would be willing to host us again.
Or John, we might be able to do it here as well.
That's right.
It might be interesting to do it at one of the rural hospitals to find out and have some of the folks come in, maybe even some of the patient experiences, because we were talking about, we hear all of the parts of it, but not from the patient and what they might find to be useful as it moves forward.
That's a great idea. So I think our rural hospital representatives are Scott Kennedy at Olympic out on the peninsula, and then Dr. Jones, who's in Newport, so way northeastern corner. It's about 90 minutes north of Spokane. Beautiful country on the Lake Pend Oreille, but I have been there, so I can check in with Jeff and see if he'd be willing to host us. It's a great idea, though. Ultimately, this is all about patients.
It is.
Yeah. Okay. Good. We have about 5 minutes for public comment. We'd love to open it up for folks who have questions or comments from the public. Anyone online like to chime in? Okay. Well, great. Well, thanks, everyone. I think we're going to end a little bit early today. Wish you all a Happy New Year, and I'll look forward to seeing you in February.